harbors of metastatic tissues. And this is another case you can see, for example, the squamous cell carcinoma on the left alveolar mucosa with the retromolar area having the trismus, and it was advanced cases having invaded the bone. So we had to resect the mandible with the lesion and also the neck contents like the modified radical neck dissection. But now we are away from the radical neck dissection. We used to do the functional neck dissection to prevent the morbidity. And after removal of the hemimandible with the lesion and the neck contents like the fibrofatty tissues, lymph nodes, and the sternocleidomastoid muscle, you can see the clear visualization of the red vessels like external carotid artery, internal carotid artery, external carotid artery. Then we become sure that we have removed clinically, and by naked eye, we have removed the source of all, the harbor of all metastatic tissues. And how do we reconstruct? If the small lesions we get the very early stage of the lesion from you people, we can easily excise the soft tissues, or we can easily excise the hard tissues, and we can close primarily without any reconstructions. But sometimes we have to do the resection of a large portion of the face, including the skin, where we need to reconstruct it in several ways, from local flap to the distant flap and the regional flaps. And sometimes some of our people already started the macrovascular reconstruction, which is very important for palliation of this lesion. And this is the pectoris major musculocutaneous flap to reconstruct a lesion defect created by the mutilating surgery involving the mandible and also the skin. And another case you can see, sometimes we think that the recurrent case should not be dealt with, but when there is any recurrence in the primary area due to failure of the clearance of the margins at the primary surgery, we can do also the secondary surgery. We can do the redo surgery if it recurs in the primary site. And in that case, we have to remove the skin and to reconstruct by the deltopectoral flap. It is one of the ways for reconstruction. And the deltopectoral flap, how reconstruct the external skin very easily by anybody. And this type of lesion we often find such a very ugly looking stage of advanced oral squamous cell carcinoma. Sometimes we treat these patients for palliation to give the confidence and to give the acceptability of the patient in the society. How can a patient survive with his family members with such a lesion? So if the survival is 1 year or 2 years, we have to do the surgery for palliation to give the patient's confidence and the acceptability to the society. And we need to reconstruct this type of the lesion by the dual flaps like the deltopectoral and the forehead flap that I have followed in this case. And the resection of this primary lesion with the neck dissection, modified radical neck dissection, and reconstruction by the forehead flap, which covers the inner defect, and the deltopectoral flap you can see which is used to reconstruct the outer defect. So you can see the difference between the before surgery and the after surgery. Sometimes survival is not important, but how many days patient will survive, we don't know. But patient should be survived with ease and with comfort. And this is inner cheek reconstruction. The patient's mouth opening is very good, and patient can take anything by this mouth opening. And this is the outer aesthetic as well as the function. Patient's aesthesis is very fantastic, and patient can open the mouth. Sometimes the trismus and complete inability to open mouth after the surgery is very common due to lack of reconstruction approach. So we have to think about, we used to think about the aesthesis as well as the function. So we have achieved the aesthesis as well as we have achieved the functions. And this, I'm going to show my survival study, which has been prepared by one of my colleague from Japan, which was analyzed by the JMP8 software, and the survival rate shown in the Kaplan-Meier plot, which is the only way to show the survival of oral squamous cell carcinoma. And the overall survival is shown, whether the disease-specific or disease-free survival. And this, by this log rank test, comparison of the survival rate is shown between the surgical and the non-surgical treatment among the T, among the N, among the M stages. And in Kaplan-Meier method, we know the censored cases who lost to follow-up or withdrawal are deleted automatically from the analysis automatically. And the result is the age range from 26 to 85 years with the average of 54 years and the standard deviation of 12. And by the distribution, the age distribution, we see this type of deletion is very common in the later stage, in the later life. But it is also, we see at the very early stage, early age, that is between the 20 to 30 years. So now, it is not considered that squamous cell carcinoma is the disease of elderly, but we also see this lesion in the early stage, early age. And the females are more affected in my study. It can differ with other studies. Females are more affected than the males. And the lower gingiva, as we know, the carcinogens are settled in the lower part of the oral cavity. So the lesions mostly seen in the lower part of the oral cavity than the upper part, which is also seen in my study. And we received most of the cases, more than 50% of the cases at the stage 4 lesion, and then the stage 3, stage 2, and stage 1. And the N stage, we most often see in the N0, which is very good sign. We can give a very good survival of these patients when the patient has no nodal involvement. And in case of general staging, we see the stage 4 lesions are common. And regarding the smoking habit, I have told that the 90% of the patients are related to the smoking or the battle quit chewing. And the overall 5-year survival, I want to repeat that this is not disease-specific or site-specific survival. This is overall survival from stage 1 to stage 4, from the lesion of the lip to the retromolar area. And in this survival curve, I can see that the overall survival rate is around more than 60%, that is 64.2%. And when in the log rank test, we can compare the survival in different stage of the patients, like and also the surgical and non-surgical treatment. This, we have very little difference between the survival of the surgery and the survival of the non-surgery, and which is almost the same scenario in the worldwide, and there are so many debates. But in case of, we can think that the no surgery, without surgery, we can give the same survival of these lesions. But the matter of the quality of the life, without the surgery, you cannot give quality of the life. So we have to go for the surgery in that aspect. And this scenario may be changed when we will see the disease-specific survival and the disease-free survival. By the surgery, we can extend the patient's life without the disease, but without the surgery, we cannot extend the life without the disease. So that is the very important. So the scenario might be changed when we'll see the disease-specific or the disease-free survival. And the survival rate according to the stage, we can see the stage 1, the survival is 100%. So the cancer means the death. This is not true. Some of my colleagues asked me, if we do the surgery, patient will die. If we don't do the surgery, patient will die. So what is the importance of doing the cancer surgery? But that's not true. In case of stage 1, stage 2, stage 3, even the stage 4, we have the 100% survival. We have the complete survival of the patients more than 5 years, 10 years. We have so many patients having survived for the last 10 years, 15 years. That depends on the stage of the lesion. And if the patient survived for 2 years, that is also important. Why don't you think that the 2 years is not important for the patient? 1 year is not important for the patient. So in my study, you can see the stage 1 lesion survival is 100%, which is reduced to the stage 4, that is 44.4%. And among the T1, specifically, you can consider the size of the and extent in the local area. We also see the same scenario. In the T1, the 5-year survival is more than 85%, where the survival is around 50% in case of the stage 4. And again, I have told that 5-year survival decreased up to 50% when there is nodal involvement. So we have to diagnose, and it is our responsibility of the whole audience to diagnose this lesion at the very early stage when we examine the oral cavity, when we will do the orthodontic treatment as well as any source of the treatment, endodontic treatment or prosthetic treatment. We need to diagnose the lesion clearly. And I will not take much time, and at the end of my presentation, I would highlight the survival steadily declined with advanced clinical stages. It is very clear to us. Detecting oral cancer in early stages offers the best chance of long-term survival. And the primary prevention is only way by telling the patients and the parties and the community to give up the habit or to stop the habit or to prevent the habit of smoking and the metal quenching, that means tobacco in different forms. Thank you very much for patience hearing.
Our next presenter is Dr. Abdullah Al Masud. He will present about change of face by orthognathic surgery.
Honorable Chairperson, learned audience, and distinguished guests from home and abroad. I am Dr. Abdullah Al Masud, working in Dhaka Dental College and Hospital as an assistant professor. Before going my presentation, I would like to thank Professor Moinjan Chaudhary and Professor Jahangir Kobil to organize such a big gathering in the history of dentistry. My today's topics about change of face by orthognathic surgery. First of all, we know what is orthognathic surgery. It's an operation to reposition the jaws in a new position, which will improve the aesthetic as well as function also. So when jaws are not properly aligned, there are lots of problems with appearance, social problem, chewing problem, and biting problems, speech problems. So the candidates of orthognathic surgeries are maxillary anterior-posterior excess or deficiency, maxillary vertical excess or deficiency, mandibular anterior-posterior excess or deficiency, mandibular asymmetry, and facial asymmetry. And there are some syndromes like as Apert syndrome, Crouzon, Goldenhar, Romberg, Perry-Robin, and Binder syndromes. And the sleep apnea due to short face. These are the candidates for orthognathic surgery. Before doing orthognathic surgery, we have to know some basic proportion of the face. Here, if we line some vertical line from the inner canthus, both inner canthus of the eye, it will go through the L of the nose. And from the outer canthus, both outer canthus, if we draw a vertical line, it will, all of this divided the face into 5 equal proportions. And face is divided by 3 parts, mid face, upper face, and lower face. Upper face from the trachea to the glabella, and from the glabella to the nasion, it's a mid face, and from nasion to the chin, it's a lower face. All should be equal. And from the prominence of the zygoma to zygoma, that is bizygomatic width, and from gonion to gonion is a bigonial width. Bigonial width is always 30% less from the bizygomatic width. If it is equal to the bizygomatic width, in case of female, the face looks like manly. So it is not acceptable. And obviously, we should see the symmetry of the face. Both sides are equal. And the smile line, you look, the left-handed side, the smile is pleasant, but the smile is gummy smile, another one. So this smile can be changed into like this by orthognathic surgery. And before doing orthognathic surgery, we go for some radiographic analysis like a panoramic X-ray, cephalometric, in lateral cephalometric X-ray and anterior-posterior cephalometric X-ray, and intraoral periopical view. So I would give some short description about the surgical procedure. In orthognathic surgery, we do 3 types of osteotomy. In case of chin, we do the genioplasty. And in case of maxilla, we do the Lifford 1 osteotomy basically. And I would like to show some video clips of Leafwood 1 osteotomy. Here you see the osteotomy outline is done from the piriform aperture to the zygoma, and there is a step cut, and from this step to the last part of the maxilla, posterior part of the maxilla. And in case of bilateral sagittal split osteotomy, we give a cut just upper to the lingula and just posterior to the lingula, and then in the external oblique ridge up to anteriorly up to the second molar, and then a vertical cut through the body of the mandible and up to the lower border of the mandible. It's a cut of this here in the body of the mandible and to the external oblique ridge to the upper part of the lingula. Now I am going to my case presentation. It's a hemifacial microsomia or golden heart syndrome. A frontal view and lateral view short of the chin, and chin throat angle is nearly straight. So left-handed sided is the initial lateral cephalometry, and right-handed side is the after leveling of the orthodontically. Then from this orthodontic preparation, we go for lateral cephalometry and tracing of this cephalometry. And in this cephalometry, we plan for osteotomy. There is in mandible, we go for BSSO and advancement zenioplasty, and in maxilla, we go for Leafwood 1 osteotomy. And so red one is the virtual treatment objective. From this virtual treatment objective, we go for the proper planning, how much bone we will advance or how much bone we will reduce to make a good shape. And here is the result of this surgery. It is anterior posterior profile. It's a pleasant profile, I think. 2 years after surgery. Another thing is that when jaws are very short, there is obviously sleep disturbance due to narrowing of the posterior airway space. Here you can see that after orthognathic surgery, after maxillomandibular advancement, the posterior airway is increased and her sleep disturbance totally resolved. It's another case of short mandible. This young boy go back from the Middle East due to sleep apnea and seek treatment here. Look the shape of the mandible and chin throat angle in the first one, then after the surgery. And here you can see the cephalometric tracing. The posterior airway space was previously only 7 millimeter. After maxillomandibular advancement, the airway is 17 millimeter now. So totally now he is free from the sleep disturbance, as well as his aesthetic also changed. It's a case of severe proclination with everted, incompetent lip and short lower facial height. And bite is totally deep bite and severe oversight. So lateral cephalometry, you can see the skeletal problem here. Then after orthognathic surgery, the profile is totally changed. Now her anterior profile is very much pleasant, and her lower facial height and mid facial height and upper facial height is now symmetrical. It's the three-quarter view. You can see the changes. Now the lip is competent. It's about only 21 days after surgery, this picture. And again, we can recapitulate this picture from top to bottom, the changes of this various facial profile, frontal profile, three-quarter view, and the lateral profile. It's another case of proclined maxillary vertical axis, and we do the Leafwood 1 osteotomy for reduction or superior reposition. It's another case of vertical maxillary axis, and you see the competent lip after operation. It's also a vertical maxillary axis, and after superior repositioning, both the orthodontics, after finishing up the orthodontic treatment, then we go for the surgery. Here, this fair lady, but when she smiles, the smile is gummy smile. We don't accept this type of gummy smile. So it is possible to make her smile by orthognathic surgery and superior repositioning of the maxilla and advancement genioplasty. Her total facial profile is changed. Here you can see the smile line before and after the picture. And in lateral profile you see before doing orthodontic treatment, middle one is after orthodontic treatment, and the last one is after orthognathic surgery. Before orthodontic treatment, look the aesthetic line. If we draw the aesthetic line, then the lower lip is far beyond the aesthetic line. And after, in middle one, it also remains that. And after orthognathic surgery, now it is clear. It's another case of bimaxillary proclination with vertical maxillary axis and short chin. You can see in three-quarter view and lateral profile, how the profile is changes after orthognathic surgery. Here, superior repositioning of the maxilla done by Leaford 1 osteotomy, as well as advancement genioplasty was done. And you look in aesthetic line, her lip positions is now normal. It's a bite after orthognathic surgery. This girl, actually, she is from Estonia. She comes in Bangladesh with her husband and seek treatment for his maxillary deficiency. She had class 3 malocclusion. The problem was that she cannot smile. After maxillary advancement, you see the lip profile changes and the bite also. It's also a class 3 malocclusion with maxillary deficiency. Here you can see the changes in bite. It's also a class 3 malocclusion and after orthognathic surgery. It's a huge maxillary hypoplasia and mandibular elongation. After Leaford 1 advancement and bilateral sagittal split osteotomy for mandibular setback. It's a huge mandibular prognathism as well as mid-face hypoplasia. And the frontal profile is after bilateral sagittal split osteotomy for mandibular setback and Leaford 1 osteotomy for maxillary advancement. Here is the bite after operation. And this is the lateral profile. You see the huge changes in this profile. First one is the facial contour angle where it is about 0.5 degree and after operation facial contour angle is minus 12 degree. And the facial profile is changes. It's another case of mandibular elongation and after orthognathic surgery. The facial profile is totally changed and the facial contour angle is totally changed. Here the facial contour angle after operation is minus 13 degree. And you see the aesthetic line is more normal. So orthognathic surgery is not a fear of subject today, and good planning and free flow of communication between the surgeon, orthodontist and the patients will result in good treatment. Thank you all. Thank you all for patience hearing.
Dr. Farzana Sultana, she will present about etiology of deep neck infection and determination of their predisposing factors and microbial patterns.
Dr. Professor Moinjan, BADI Scientific Committee, and BADI for giving me the opportunity to present my topics here. Today my topics is etiology of deep neck infection and determination of their predisposing factors and microbial pattern. I am Dr. Farzana Sultana from Dhaka Dental College and Hospital. Introduction. Deep neck infection is an infection in the potential spaces and fascial planes of the neck, either with abscess formation or cellulitis. The main factors responsible for this are the poor level of the dental hygiene. Dental pathology is most common etiology. Some predisposing factors like systemic diseases, diabetes mellitus, anemia, other systemic diseases like renal or liver diseases may causes predispose the deep neck infection. Appropriate treatment can be provided if we find the predisposing factors and etiological factors, then we provide the appropriate treatment to the patient and reduces the mortality and morbidity. We all know the cervical fascia. It has two layers, the superficial layer and deep layer. Usually the deep neck infection occurs between the layers of the deep cervical fascia. Objectives of my study: to see the incidence of specific space infection according to the patient's age, sex, and anatomical location. To see the etiological factors to determine the source of infection, to evaluate the causative organisms in different locations of the abscess, and to establish the correlation between the causative organisms and the etiological factors. And last of all, to determine the predisposing factors of the deep neck infection. Inclusion and exclusion criteria. Inclusion criteria: patients having the deep neck infection. Exclusion criteria: patients having infections related to external neck wound, dentoalveolar abscess, preauricular abscess, external orotid canal abscess, and patients refusing to attend regular follow-up and refusing to include the study. Materials and method. Place of study. Actually, this study was conducted in Dhaka Dental College and Hospital and Department of ENT in Dhaka Medical College and Hospital. Study period, it was the time 2010 to January 2010 to March 2011. Overview of the study design: it was a cross-sectional study. Before that, she took 2 weeks treatment under general surgery department in Enam Medical College and Hospital. But she appeared like this, and there is a severe complication with neck rigidity, and we do the surgical drainage and extraction of the offending tooth. Then the final feature of this patient. This is another patient who was admitted in Islamic Bank Hospital more than 15 days, and then he referred to our department, and they extract the tooth, but they do not